Hey, what up all my tooth doctors and doctresses? Welcome to another video at the Tooth Factory. Today we're going to continue with the Autonomic Nervous System lecture series with Adrenergic Pharmacology, created by Dr. Kalan Shah, presented by myself, Dr. Rishi Shah. Just a little revision on the fact that this is designed to help you pass exams like the AFK in Canada, the INBDE in the States, and also help you study for your actual dental degree programs and potentially help you clear the NEET as well. And this lecture is on adrenergic pharmacology. It's the counterpart to the parasympathetic system, which is known as cholinergic. This one is sympathetic. Again, this is for fight and flight. Basically, when our body goes into an emergency state, it automatically, non-voluntarily acts by itself to help us maintain that balance. So let's get on with today's show. We're going to take a look at the nervous system background and the autonomic nervous system. This is going to be quite brief because we covered this in the previous lecture very easily. However, the adrenergic pharmacology will be much more in depth in terms of the drugs used, such as agonists, and antagonists, such as the anti-adrenergic or the blockers. And then some very important concepts followed by references. We'll submit our lecture today. So just a little introduction per se. The sympathetic actions in our entire body are represented by the red. For example, if you look at the heart, when sympathetic nervous system is active, it tends to increase the heart rate, increase the contractility, which means all the functions of the heart, such as the blood pressure and the heart rate and the cardiac output, goes up. For example, in the kidney, it increases the secretion of renin when the beta-1 receptor is activated. However, it decreases when alpha-1 is activated. And we'll take a look at all of these actions in the following slides, so nothing to worry, you guys. We'll take more in-depth knowledge and learn our tips and tricks like we did for the other lecture. So just a little revision from the previous lecture. Our nervous system is divided into central nervous system and peripheral. The central, we know it's brain and spinal cord that kind of controls literally the whole body anyways. But the peripheral nervous system is divided into somatic and autonomic. Somatic is, by soma, we know that it means the body, and it's the controlled, the voluntary movements such as making a fist. Autonomic nervous system, on the other hand, is involuntary, split into sympathetic and parasympathetic. The sympathetic is what we're going to talk about today, and for parasympathetic, please click on the card right here. That'll help you take you to the parasympathetic nervous system, the cholinergic videos. Now, what is the autonomic nervous system? It is a balance between parasympathetic and sympathetic nervous system. Remember, parasympathetic is something that keeps you calm, versus sympathetic is something that gives you the emergent response, right? The fight or flight response. And the balance between these is essential to maintain the equilibrium of the body, right? Because if, for example, if the sympathetic was really high, then your heart rate and your blood pressure will always be high. That's not great, right? So when this happens, our body detects it and parasympathetic nervous system kicks in. And vice versa, when our blood pressure and heart rate are really low, the body kicks in the sympathetic nervous system and it fights that scenario. So they're both involuntary, both are opposite in action, however, still under the umbrella of autonomic nervous system. So that concept must be very clear, guys. And when it comes to the drug classification, we already talked about the cholinergic family. This one we're going to speak of adrenergic family, the sympathetic and their blockers. Okay, so for this lecture, we're going to keep this section away from us. However, we've kept it in here so that when you write notes during the lecture, it's easier for you to follow along. So for sympathetic nervous system, it being the fight or flight, we know now that we call it the adrenergic system. Now, before we move ahead, I do want to point out why it's called adrenergic. There is a hormone in the body known as adrenaline. Adrenaline is responsible for giving you a rush. Remember? The adrenaline rush is what we call it. Well, in other words, that hormone or neurotransmitter per se is known as epinephrine. Therefore, the sympathetic nervous system communicates. The peripheral nervous system communicates with the end target organs, whether it is muscles, whether it is eyes, whether it is the heart, doesn't matter. The sympathetic section of the parasympathetic nervous system communicates with the target organs using epinephrine or norepinephrine as neurotransmitters. So we're going to talk a lot about epinephrine. And by the way, just a little heads up, epinephrine is an essential component of local anesthesia because it causes vasoconstriction. Okay, anyways, the receptors. So every target organ, such as the muscle and eyes, they have receptors on them. Now, in sympathetic nervous system, we have alpha 1, alpha 2, beta 1, beta 2. Beta 3, it exists in physiology, but we're not going to talk much about it. So alpha 1, alpha 2, beta 1, beta 2 are the target receptors. And when I say target, keep that in mind because these do not, and this is very important, please write this down, do not exist at ganglions. And I know we've introduced this word in the previous lecture, but for those who are watching this for the first time, ganglions are very important components of a neuron transmission. It's how a CNS, or in this case, peripheral nervous system, communicates with the target organ. It has to go through a ganglion. We'll take a look at it in just a second. However, the target or target receptors are alpha 1, alpha 2, beta 1, beta 2. Fair enough, guys? Let's move on. This is what a synapse looks like. This is neurotransmitters between the presynaptic vesicles and the postsynaptic receptors. This is what we are going to speak about today, norepinephrine and epinephrine. The impulse goes in this direction towards target tissues. Again, they could be things like muscle, gland, heart, eyes, and many more. Enzymes. Now, obviously, there's enzymes in the middle of synapse that would help do one of the two things. It would either improve this communication or it would block it. But today we're going to talk about two enzymes. It's called monoamine oxidase and COMT. These two enzymes, please write them down, that these two enzymes are going to prevent epinephrine, norepinephrine, from communicating. So in other words, it will break down, right? Remember, anything that has A's in it, like monoamine oxidase, it will break the enzyme down, or the neurotransmitter down, I apologize. It will break the neurotransmitter down. And then we know that these receptors right here are either alpha 1, alpha 2, beta 1, or beta 2. Fair enough, guys? Okay. Now let's take a look at this diagram from the perspective of our textbook and reference, for which the link is in the description box below. And again, if you have any questions conceptually, please reach out to us via the comments below or our social media pages. We would love to help you and fix your doubts regarding pharmacology per se. So in the autonomic nervous system, let's focus on the sympathetic, where there is a ganglion and there is a target. Fair enough? So this diagram right here is very generic, right? This is where the CNS is. That begins the communication through pre-ganglionic neuron. That makes this area a ganglion. And then towards an effector, or in other words, target organ, using a neurotransmitter in the post-ganglion. So that makes this a ganglion. Now the rule was that all ganglions, right? Again, write this down, guys. All ganglions are nicotinic. And this brings us back to our previous lecture in cholinergic, that all ganglionic receptors are nicotinic no matter which system we come from. Because they're nicotinic, they can only accept acetylcholine. So the rule was that all preganglionic neurons will consist of acetylcholine as a neurotransmitter. Even in the sympathetic nervous system, it will touch down at the ganglion. Remember the flight scenario, that from our beginning location, the flight takes off, called as ACH, lands at a connecting airport, and then it takes off again in a different flight because it needs to reach not a muscarinic or a nicotinic receptor. It needs to reach an adrenergic receptor. Therefore, since the destination changed, the flight changed to norepinephrine in the postganglionic neuron to reach the adrenergic receptor. So let's take a look at this in a notes format. So to help you guys write this and remember this, we've created this little train. That train is basically this synapse being at the ganglion right here, where PNS, the peripheral nervous system, part of the autonomic nervous system, that can be split into parasympathetic or sympathetic, begins as a common format, where preganglionic neurotransmitter is always acetylcholine. The reason being is because the ganglion has a receptor where the preganglionic neurotransmitter sets in. If this is cholinergic, this has to be cholinergic, correct? And that's why all ganglionic receptors are nicotinic. Now, after the connecting flight that leaves the connecting airport, the postganglionic neuron can either be norepinephrine or acetylcholine. This is because the target organs have two different types of receptors. They can have a cholinergic or an adrenergic receptor depending on what the action needs to take place, depending on whether parasympathetic kicked in or sympathetic kicked in. So if it's cholinergic receptor at the target tissue, we know for sure that the neurotransmitter will be acetylcholine, which means you don't have to change the flight. You just sit on it, let the flight refuel, and move towards the target. But if the target tissue needs the help from sympathetic nervous system, then the adrenergic receptors need to be filled, and they are alpha or beta receptors. In that case, it has to be norepinephrine that leaves the ganglion. Fair enough? So let's dive in a little deeper. Okay, so let's talk about sympathetic nervous system. Now, sympathetic nervous system, when we speak of it, two things initially pop up. We've just learned about them. It's epinephrine and alpha beta. These things pop up very easily. However, we know that preganglionic is always going to be ACH, acetylcholine, towards a ganglionic receptor of nicotinic, but later on switches to epinephrine, which then goes to alpha 1, alpha 2, beta 1, beta 2 receptors located at target tissues such as smooth muscles, glands, and heart. Now, I know we've always talked about sympathetic always being epinephrine, then what is this doing here? Well, there is one slight modification, that when it comes to sweat glands, the sympathetic nervous system kicks in acetylcholine towards the muscarinic receptors. I know this is an exception, however, this is not important when it comes to dental pharmacology, but it is a part of physiology, therefore we did mention the statement. So we know that the sympathetic nervous system is a flight or flight response, adrenergic pharmacology we call it. It has to do with arousing effects with agonistic, which means it will increase the effects of the system or the targets it attacks. Neurotransmitter will be epinephrine or epinephrine. Receptors, we know that ganglion will have nicotinic, alpha beta at the targets, and it is generally an emergency response of bodily function with a non-voluntary control of the body. All right, let's now talk about the pharmacology. Do you remember how ACH was also a part of the previous slide? Well, that's why we call it predominantly sympathomimetic. Now, any agonistic activity, which means something that helps the adrenergic pharmacology, is what we call a mimetic, right? So there are two words we will look at, a mimetic versus a lytic. So write this down, guys. Whenever you see mimetic, we talk about agonist. Whenever we see lytic, in other words, to cut, we mean antagonists. or blockers. It's what we call blockers. Okay, so in adrenergic pharmacology, there are three types of drugs that we will encounter: direct acting, mixed action, and indirect acting. In other words, the direct acting will act directly on the postsynaptic receptors such as alpha beta. So right here, what it will do is it will enhance the effects of norepinephrine to be able to attach itself to the postsynaptic receptors. It activates the receptors very well at the target cell. Indirect acting, on the other hand, enhances the release of norepinephrine from the vesicles. So this vesicle that protects the norepinephrine from degradation, indirect acting adrenergic agonist, they will enhance the release of norepinephrine from the vesicle. And mixed action, as it says, direct stimulation of the target, as well as enhancing the release of norepinephrine. So it works in both directions. Okay, so one of the most important concepts, especially back in cholinergic lecture, as well as this, we need to understand how they come to be. Now, why do we need to do this? We need to understand where all the drugs act. That's why this is important. So let's take a look at our train of events right here. See, first of all, we need to know how norepinephrine is synthesized in our body. It's synthesized by a reaction right here called hydroxylation of tyrosine. So first of all, there is a molecule named tyrosine that enters this axon right here using the sodium pump, and tyrosine then gets hydroxylase into what is called as dopa, and dopa then gets converted into dopamine, a word we know, right? Did we know that dopamine was the precursor to norepinephrine? Very cool. Because see how dopamine is still outside of the vesicle? Well, it needs to be uptaken into the vesicle for storage, right? Because not everything's going to be used up this quickly. Therefore, when dopamine is made, it gets stored in a vesicle. As it enters a vesicle, it is converted into norepinephrine. And norepinephrine is now protected from degradation. What does that mean? Well, it means that if norepinephrine was in its raw state outside the vesicle, it would get degraded. Therefore, dopamine became the protector of norepinephrine, put it into the vesicle without anybody knowing, and now norepinephrine is safe. See, because what happens is if this dopamine is caught by all these police officers walking around right here, then the transport into the vesicle is going to be inhibited. Now, what are these police officers? They're known as reserpine. This is a drug that we will talk about at the end of our lecture today. That's where we will end it, right? So, reserpine is a drug, pharmacologically created drug, that inhibits the transport of dopamine into the vesicle and prevents the conversion into norepinephrine. What does that mean? It means that there's no norepinephrine right here because it got degraded. Therefore, that makes reserpine a anti-adrenergic drug. Now, why am I jumping to the conclusion here? I'm jumping because we need to know the story really well. That's why I'm making our discussion a little longer here so we can understand the steps. Okay, guys? All right. Moving on to the next step here. Now, because it's in the vesicle, we know it's safe. Afterwards, it needs to be released from the vesicle in order to be used. So step 3 is release of neurotransmitter. The only way that can happen is by a positive energy. By positive, we need calcium. When calcium acts, there is an influx of calcium, and then the cell membrane will open the vesicle, known as exocytosis. Exocytosis means outside of the body. That's all it means. So it releases norepinephrine outside of the vesicle into the synapse so that it can act and create responses in the postsynaptic targets. However, there's another villain right here. It's waiting for norepinephrine to kind of peak out. As soon as it does, it will stop it. That is known as guanethidine. And that makes guanethidine an anti-adrenergic drug as well. So look how we simply cleared one of the best concepts of reciprine and guanethidine. It prevents norepinephrine from going to the target tissue. However, let's say guanethidine got bypassed and norepinephrine made it to the synaptic membrane. Then it still has to bind to the receptor, right? Well, the postsynaptic receptors such as alpha-1, alpha-2, beta-1, beta-2 will gladly accept norepinephrine. That can lead to an intracellular response at the targets. However, wait for it. There's more villains out there. There's something we like to call as COMT or MAO. Now these guys right here are the cops, the police officers of the synapse. So again, what is COMT? It is known as catechol-O-methyltransferase. And what is MAO? MAO is monoamine oxidase. Every time we hear the words A's, what do we think? We think breakdown. Therefore, it is responsible for the breakdown of norepinephrine into its miniature molecules that will metabolize and then remove norepinephrine from the synapse. So when the release of norepinephrine is rapidly taken up into neurons, we know that in that area there are some good people waiting, such as when the reuptake is inhibited by SNRIs, cocaine, and the other drugs. Now what are these drugs? These drugs are pro-epinephrine. They're going to allow epinephrine to remain in the synapse. They will fight these cops right here and prevent the breakdown of norepinephrine, and it will help attach it to the intracellular response by increasing its concentration. Okay, last but not the least, I'm going to clear the slide to show you guys something really cool. Okay, so far we saw the entire lifespan of norepinephrine and the challenges it faces. But there's this one weird challenge that norepinephrine faces, and it's located at the presynaptic receptor. In other words, it's alpha-2 receptor. Now write this down, guys, because if we clear this in this photograph, the future slides will be much easier. What I mean is that norepinephrine has three ways to go once it's in the synapse. One is intracellular response at the synaptic receptors, postsynaptic receptors. Second is becoming metabolized into other smaller molecules by COMT and MAO. But the third consequence of norepinephrine is alpha-2 receptor. It accepts the norepinephrine molecule as an adrenergic receptor, but then it sends it back into the vesicle. What kind of a agonistic receptor is this that it takes norepinephrine and brings it back into the vesicle? Well, it may sound like antagonistic, however, it's a good receptor. Because what it does is it lowers the toxicity of norepinephrine. See, let me give you a little scenario. See how we know that these happy molecules right here, the SNRIs, the cocaine, and the other drugs that enhance norepinephrine into the synapse, right? It inhibits the reuptake of epinephrine. Well, doesn't that make this very highly toxic in consideration of the concentration of norepinephrine? Absolutely. Well, that's when we need our own safeguard, the alpha-2 receptor. It will take all of the unused, unnecessary norepinephrine and bring it back to the vesicle. It'll recycle it. That's why, even though it reduces the concentration of epinephrine, it is a positive receptor. That's why alpha-2 is in agonistic categories. Even though the actions, the mechanism of action, the function, everything is opposite, we still call it an agonistic receptor. Okay? So let's take a deeper look. Adrenergic receptor functions. Why is this important? This is important because when these are activated, they have an exact response according to the locations. That can help us understand the drugs that are coming in the following slide. So when alpha-1 is activated, what happens? In the agonistic activity, what happens? Well, alpha 1 is peripheral. Just remember that. Peripheral. Alpha 1 is all periphery. It can cause vasoconstriction in the periphery. It can lead to increased peripheral resistance, increased blood pressure due to the constriction of the vessels, and it can lead to mydriasis, which is basically, this is your eye, this is the eyeball, and it can lead to a dilation of pupil. It will make your pupil big, so your farsightedness is accommodated. And bladder sphincter closure. So in other words, it reduces urine output. You know why? Because it increases the muscle activity of the bladder. It closes the sphincter. Okay? Now alpha 2. Now I'll skip this for just a second, but we'll talk about this in the next slide and come back. Let's move on to beta 1. When beta 1 is activated, we know that the actual dominance is definitely on heart, but it can also act on the kidneys. Okay, so let's talk about beta 1 as a heart receptor. It can cause tachycardia, makes the heart beat faster, heart rate goes up. It increases lipolysis. Remember, lysis means to cut, lipo means fat, so it technically burns fat. Remember, when you do cardio, your heart rate goes up and it burns fat. Just another way to remember it. Increased cardiac muscle contraction, so increases cardiac output and thereby increases blood pressure directly from the heart. At the kidneys, it increases renin release. Renin increases, and that increases blood pressure. Remember that in the antihypertensive drugs, we have a drug that prevents the entire renin-angiotensin system. Well, that's because we want blood pressure to go down. But what happens when renin is increased? Well, blood pressure goes up. That's why beta 1 is acting on the heart and kidneys directly. Beta 2, a little opposite to beta 1, but it acts on lungs. That's what we need to remember. So vasodilation and bronchodilation of lungs. So remember this, when we have an anaphylaxis, what happens? We get something we know as bronchoconstriction. And then it's really hard for us to breathe, right? And so what do? We shoot an EpiPen, epinephrine. When it goes and acts on the lungs, it leads to bronchodilation. Right? When you activate beta 2 receptors at lungs, it will cause bronchodilation, and that's why epinephrine is used to relieve anaphylaxis. It can then also decrease blood pressure, decrease PVR, the peripheral vasoresistance, and increases glycogenolysis. This is new. Glycogenolysis. When sugar is stored, it is known as glycogen. Lysis means to cut. The storage of sugar is opened. That makes the blood sugar level go up. Okay? And it relaxes the uterine muscles. That's for labor pain during childbirth as well. Okay, so as promised, alpha 2 receptor activity in the picture first, then the chart. So remember we said, this should be easy now, guys, that presynaptic vesicle will have vesicles with epinephrine in it that tend to go out with calcium being involved, right? Epinephrine goes out, attaches to the receptor, and voila, we have action. But whenever there's too much of epinephrine, there is the alpha 2 receptor at the presynaptic vesicle that will attract the epinephrine and put it back into the vesicle. This will cause a reduction in the epinephrine release, so it can control epinephrine or norepinephrine at synapse. So let's go back and find out what it really does. It's located at the presynaptic membrane. Anti-adrenergic effects are obviously provided by it because it decreases the inhibits the norepinephrine release, it also has inhibition of acetylcholine release. Therefore, it kind of has anticholinergic effect. And by rule, opposite action, it inhibits insulin release, such as renin release. So all it does here is that it kind of controls the norepinephrine activity. So let's just remember that. Okay? Okay. So, furthermore, the decrease in the release of norepinephrine from the presynaptic vesicles will help prevent non-epinephrine toxicity to help postsynaptic activity control. So remember this. This is a picture from our reference that alpha-2 receptors, the activation of receptor decreases the production of cyclic AMP, leading to the inhibition of further release of norepinephrine from the neuron. So norepinephrine then is decreased in release. However, on the postsynaptic membrane, there's alpha-1 receptor, which actually accepts all of these norepinephrine and causes an action in the target tissues. Now, this is an example of alpha-2 agonist drug known as clonidine. The treatment of hypertension is done by clonidine. How so? Well, we know that when epinephrine is attached to a beta-1 receptor at the heart, it leads to increase in blood pressure. In other words, hypertension, right? But what if we take away that epinephrine and put it back into a presynaptic receptor? Then beta-1 cannot be activated, heart cannot be activated, blood pressure cannot go up, and hypertension is treated. Simple. Therefore, the decrease of norepinephrine release leading to decrease of activation of epinephrine receptor at the target, so no hypertension. Fair enough? Great. Now, remember the same format that we had in the previous lecture. We'll have the target tissues and their agonistic activity. Now, the reason why we're taking it overlappingly is because physiology and pharmacology is being mixed here, guys, and clarifying all of these concepts are crucial. So, cardiovascular system. What happens when sympathomimetic, the agonist, affect the cardiovascular system? Well, we now know that it increases contraction of the heart muscle. Therefore, it increases cardiac output and blood pressure, and increases total peripheral vascular resistance. This is alpha-1, this is beta-1, this is beta-1. So always link your receptors with the activity to train your mind into understanding the concept. So if I ever tell you that I have a drug that is beta-1 agonist, then instantly we know that, oh, cardiac muscle. If I say alpha-1 agonist, then we know, oh, it's PVR. These types of relations need to be made, you guys. Okay, in respiratory system, the lungs. Remember, as soon as lungs kick in, our minds are drawn to beta-2, right? Well, it relaxes the smooth muscles of the respiratory tract, causing bronchodilation in the treatment of anaphylaxis. Remember the story from a previous slide, guys? Great. Okay, central nervous system. This is new. We haven't talked about this yet, but it tends to stimulate the CNS and causes alertness. However, high doses can be harmful because it can cause tremors, restlessness, anxiety, apprehension, these types of things. Metabolism-wise, we talked about lysis, right? Glycogenolysis. So when sugar that is in storage is broken down, therefore released into the blood, causing increase in blood sugar levels, leading to what is now known as hyperglycemia. And this is, remember, beta-2. Eyes and vision, we know that it dilates the pupils and causes mydriasis. Which receptor was this, guys? Alpha-1. Okay. So when should we be using the sympathomimetic agonists? Well, when we want to control bleeding and maintain a dry field. Right? Vasoconstriction by alpha-1. Prolongation of local anesthesia, reducing the risk of local anesthesia toxicity. Vasoconstrictor in local anesthesia. Whoa, what does all of that mean? Well, think of it this way, guys. When blood vessels are constricted, then blood cannot flow into all directions. Therefore, if blood cannot flow and is pooled here, and I bring in an injection of local anesthesia, will local anesthesia be able to go out? It can't go out because vasoconstrictor has stopped the flow of that blood, has restricted the flow of the blood. Therefore, local anesthesia is safe here. So we cannot have a local anesthesia toxicity. And because it cannot flow elsewhere, it will have a prolonged effect rather than a diluted effect. That's just a story to visually remember how vasoconstrictor and local anesthesia, such as epinephrine, work. Now, treatment of cardiac arrest to increase the blood pressure. We know that beta 1 helps in all of that. Treatment of asthma and allergic emphysema. So this is all beta 2, guys. Remember, anything with lungs, beta 2. Asthma has what? Bronchoconstriction. So beta 2 activation would cause bronchodilation. Emphysema has what? Inability to exhale. That is basically another restriction of respiratory tract muscles. Therefore, activation of beta 2 will help fix that as well. Treatment of ADHD and narcolepsy. ADHD and narcolepsy is basically the lack of activation of CNS. What does sympathomimetic drugs do? They stimulate the CNS system. Those are the indications of sympathomimetic agonist. But they always come with side effects. We know that increase in blood pressure leads to hypertension, increase in CNS activation leads to tremors and anxiety, tachycardia is increase in heart rate. This is irregular heartbeats, so arrhythmias. And blurry vision because of mydriasis caused by alpha-1 receptor. Okay, now let's jump into the drugs. Now all we have to do is we know what type of actions adrenergic drugs have, we know what receptors they act at, and we also know what each receptor is responsible for. So all we need to know is names of the drugs and where they act. How simple is that, guys? So let's talk about direct acting drugs at the specific receptors themselves. Dopamine, epinephrine, dobutamine. Albuterol, phenylephrine, salmeterol, terbutaline, another albuterol, and many other drugs are specifically direct acting. They have a destination that they will act at directly. Some may have, say, 4 receptors that they act on. Some may have 3 receptors that they act on, right? Mixed acting, ephedrine and pseudoephedrine. Indirect acting are amphetamine, cocaine, and tyramine. Now, how do you remember all of these names? Well, these won't be too hard to remember because we've already seen we've always heard of these names here before. So these are direct acting adrenergic. However, ephedrine and pseudoephedrine are basically those drugs that have epinephrine activity at dual stations, or epinephrine activity at dual stations that could just be fake epinephrine. Clear? Epinephrine, dual activity, or fake epinephrine that has dual activity. These are mixed acting. So just a way to remember and split the words up so visually we can remember them. Indirect acting. Indirect acting means they increase the norepinephrine release. So remember this. Cocaine gives you a high, right? So don't ever take cocaine, guys. Just a little disclaimer. But cocaine gives you a high, but not directly. It'll always take the back door into our body just when we don't know, and it'll kick in and give us a high. So remember that it's indirectly acting. Perfect? Amphetamine. Tyramine. How do you remember tyramine? We'll get to amphetamine in just a second. How do you remember tyramine? Cars have 4 tires, but we always think that our engine runs the car, right? But in reality, the engine could stay there stationary unless indirectly tires were running the car. So that story could help you remember tyramine. Amphetamine. Now amphetamine is interesting. Remember these 2 words, dimethylphenidate and amphetamine. These 2 are actual drugs out in the market that increase CNS activity. How do you remember that? Well, what is CNS? A bunch of electrical components, right? I'm going to write here. Electrical components are neurons, and there's an electrical component into our brain when they communicate, right? What units can be used for electrical components? Amps. So amphetamine. Let's remember that. And dimethylphenidate, it's basically the same thing in a different format, but how do you remember it? DMP. Dimethylphenidate. How do you remember DMP? Well, it's the sister to AMP. Fair enough? I know these stories, again, they might be a little silly to remember, but they help us visually learn and put a pattern into our minds. So let's take a look at all of these drugs one by one, and we'll conclude our session for today. Direct-acting adrenergic agonists. Let's take a look at all of these drugs for once, guys. Epinephrine. We know that epinephrine is the king of adrenergic drugs. It treats emergency cases of anaphylaxis, treats bronchospasms. It can be used in the treatment of asthma because of bronchospasm treatment. It is used as a vasoconstrictor in local anesthesia. But for all of these to occur, it has to act on all 4 receptors, right? It jumpstarts a heart when we have a cardiac arrest. It creates bronchodilation at beta 2. It has an emergency action of vasoconstriction caused by alpha 1. So it has to act on all of them. Again, alpha 2 is our unfriendly friend. So let's keep it out of the equation for now, because the only drug that we need to be concerned about when it comes to alpha 2 is called clonidine. Okay? All right, norepinephrine. It is used in the treatment of hypotension. So if hypotension is our goal, then norepinephrine will be acted on alpha 1, alpha 2, and beta 1, not beta 2. We don't need any lung activity here. Perfect? Dopamine. Congestive heart failure. Dobutamine. Congestive heart failure. The only difference is that dopamine is activated on all 4 receptors. Now, how do we remember that? Well, remember that dopamine was the precursor to epinephrine. So wherever epinephrine acts, that's where dopamine acts. However, dobutamine, still in the treatment of congestive heart failure, it is activated mainly on beta 1, not beta 2. Very minimal on beta 2. Phenylephrine. Phenylephrine is used in decongestion of the nose and pupil dilation. So eyes and nose, right? Eyes and nose. Eyes and nose. N and E. Just a visual learner, guys. I know all of them have it, but this way it's easier to remember. Alpha 1, minimal alpha 2. Why? Because alpha 1 has to do with eyes, midriasis, remember? That's the way to remember, you guys. And then when it comes to salmeterol, formoterol, albuterol, terbutaline, these guys are anti-asthmatic drugs causing bronchodilation. It's an emergency drug known as salbutamol. However, these guys, such as salmeterol and formoterol, are long-acting drugs. Albuterol and terbutaline are short-acting drugs, specifically on beta 2 because we need lung activity here. Perfect, you guys? Great, then let's take a look at indirect acting, our AMP, our CNS drug. Another one was dimethylphenidate, the DMP. Remember? Perfect. So, dimethylphenidate. Treatment of ADHD narcolepsy, because it increases the norepinephrine release, causing CNS stimulation and CNS stimulation. Fair enough, the same family of electrical charges increasing the CNS activity. And cocaine, the guy that takes the back door and kicks us up by increasing both CNS and CVS stimulation. But it's damaging because it's always indirect. It's never a good drug. Don't do cocaine, you guys. No, just kidding. Well, don't do cocaine. I'm not kidding. Okay, the mechanism of action is that it prevents the reuptake of epinephrine, increasing the synaptic epinephrine levels. Remember that really early diagram we saw today that says there were some actually happy molecules such as SNRI and cocaine Well, this is that group of drugs that prevent the reuptake of epinephrine into the the vesicles, and therefore the synaptic levels of epinephrine are increased. When that happens, they go to beta 1 because they have to go somewhere, and the heart starts racing, and so is our CNS. Okay guys, those are indirect acting. Mixed acting, drugs that do both. They have dual actions of epinephrine, or sometimes known as fake epinephrine. Now, not really, but just a visual way to remember ephedrine and pseudoephedrine. What they really do is they act on alpha-1 directly. Now, when they do alpha-1, they have increased blood pressure for treatments of hypotension without bradycardia and treatment of nasal decongestion, and pseudoephedrine for nasal decongestion, oroenteral communication. Okay, so let's not mix this up with epinephrine itself, because epinephrine will cause tachycardia. So when there is a condition of hypotension without bradycardia, that's when we use ephedrine, because all we want is increasing blood pressure. We have nothing to do with heart rate. But if we want to treat bradycardia, for example, I'll erase everything on here just so we understand. For example, if this was with bradycardia, then we're going to need epinephrine itself that works on the heart, that works on the vessels, and all of the receptors at once. Okay, that's why this is ephedrine, not epinephrine. Okay, let's talk about anti-adrenergic pharmacology, known as sympatholytic or antagonists that prevent the sympathetic nervous system from acting. In other words, anti-adrenergic pharmacology. So this should be extremely easy, guys, because we've already seen what all of these receptors do when they're activated. In this case, we're going to work opposite and add a blocker right after its name. And sorry about this, this is beta 2 receptors, you guys. Okay, so when alpha-1 is blocked, what happens? Vasodilation. Perfect. Alpha-2 is blocked. It prevents the stoppage of norepinephrine, which means it increases norepinephrine in the synapse. When beta-1 is blocked, then what happens? Well, it decreases cardiac activity. Perfect. And when beta-2 is blocked, it affects the respiratory tract and lung hyperactivity. But instead of decrease here, guys, and this is a typo, so please correct this in your notes, it is increases respiratory tract activity. Remember, when beta-2 was activated, it caused bronchodilation. It decreased the activity when beta-2 was activated. But this time, we're going to block beta-2. Therefore, what will happen? We will have bronchoconstriction. And to allow constriction, we have to have increase in lung activity. Okay, that's why it is increase. Sorry about that, guys. Now, important concepts to grasp about anti-adrenergic drugs. These are just a little thumb rule. There's non-selective and selective blockers. What that means is they could be non-selective alpha-1, alpha-2 blockers, or they could be non-selective alpha-1 and beta-1 blockers, or there could be non-selective blockers, basically just a class of blockers, or selective, that, oh, I'm only going to block beta-1, or I'm only going to block beta-2, things like that, okay? It acts exactly opposite to adrenergic agonist. And third rule is, alpha blockers are normally recognized by the words zosin, as they end in zosins. However, beta blockers are recognized by olols, right? So I'll give you a name here. Prazosin is an alpha blocker, or propranolol. Olol. It's a beta block. We'll take a look at them in just a second. Antagonists can also work by affecting neurotransmitter release themselves. Now, why is this important? Neurotransmitter release. Doesn't it sound like we've already heard this somewhere before? Do you guys remember the first two drugs we talked about? Reserpine and guanethidine. They affected norepinephrine release from the presynaptic vesicles. We'll take a look at them in a few slides. And again, we're back to the same format. Adrenergic blockers, cardiovascular system. The reason why this is bolded and all of these are not bolded is because this is important and this is less important. Fair enough? Great. Let's take a look at the opposite actions. Cardiovascular system. It reduces activity of the heart, causes bradycardia, reduces blood pressure, decreases peripheral vascular resistance. And this is easy because we know it's the opposite of agonistic activity. In respiratory system, we just talked about it causing bronchoconstriction and increasing the mucus secretions. Gastrointestinal system, it increases the motility and peristalsis, and it enhances, propagates the gastric emptying. In very common words, it causes diarrhea. Excretion gland, it increases urinary tract excretion, increases lacrimal secretion, increases salivation. So all the types of gland activities and muscle activities at these smooth muscle glands are increased. At the eyes, we can easily say that it causes miosis, it can constrict the pupil, and it can accommodate near vision this time, not far vision. Okay, antiadrenergic indication. So when are we going to use antiadrenergic drugs? Well, Raynaud's syndrome. What's Raynaud's syndrome, guys? Well, it is when in extreme cold, this is a terrible, terrible hand, so forgive me, guys. In extreme cold, our fingertips will not receive any blood supply. So it'll freeze, it'll really freeze, then turn into white, then turn back into red when the blood supply returns. So all of that is because of insufficient blood supply or vasoconstriction. So Raynaud's syndrome is treated by vasodilation, and that's why antiadrenergic, specifically alpha-1 blockers will help treat Raynaud's syndrome. Hypertension is another indication to use beta blockers. Pheochromocytoma. This is, remember from cholinergic videos, this is the benign tumor of medullary in brain. Treatment of angina and myocardial infarction. This is when we don't want increased heart activity. When there's too much heart activity, there's lack of blood supply, right? We can't have this. That's when beta blockers are used. Glaucoma and migraine and anxiety. These are indications for antiadrenergic drug. Now, remember for glaucoma, what happens was there's an increase in intraocular pressure, and therefore we need to reduce it. We need to increase the drainage of it. Therefore, antiadrenergic drugs, specifically alpha-1 blockers, will help reduce the intraocular pressure, treating glaucoma. And migraine and anxiety, this is when there is way too much stimulation of the CNS, which is seen in adrenergic effects. Antiadrenergic will prevent that. Way too much stimulation. It will prevent that. Migraine is what? A lot of pain in the head. And that's because there's so much going on in our minds. And that's why this prevents that. Just another way to remember, you guys. So what are some side effects of antiadrenergic drug? There's reflex tachycardia. When we try and treat tachycardia, our heart will go all the way down to bradycardia and kick back up and say, oh, I'm going to reflex. I got a tachycardia. That's when we use alpha blockers. That's what happens when we use alpha blockers. Postural hypertension, same thing. When we use to treat hypertension, say when we use alpha blockers or even beta blockers, our body goes, oh my God, my blood pressure is going way too high and I'm going to treat it with alpha and beta blockers, and oh my God, it goes way too low and our blood pressure drops even below what is known as hypotension. So that is known as postural hypotension. Bronchoconstriction for beta blockers, beta 2. What does beta 2 cause? It causes bronchodilation. When we block it, it causes bronchoconstriction. Bradycardia, we know that beta blockers directly work at the heart to stop the activity of it, leading to a much reduced heart rate. Hypoglycemia, we know that beta 2 works to increase the blood glucose levels, but beta blockers will stop that and lead to a decrease in blood glucose levels. Now remember, these are side effects. not actions. So when too much of blockers, too much of blocker activity is done, that's when these things happen. Decrease the duration of local anesthesia. When too much of the blocker, remember that vasoconstriction by alpha 1 agonist causes increase in the duration of local anesthesia because it would keep the LA in place, whereas the side effect of alpha 1 blocker is vasodilation, and that will allow LA to kind of go around and dilute itself. Therefore, the duration of local anesthesia would decrease. It would dilute itself out. Just another historical way to remember. So let's put some names. Remember alpha blockers, zosins. Beta blockers, olols. And we know this gang right here, we've already talked about these. So this should be easy, guys. So alpha 1 blockers. We know that there is non-selective and selective alpha 1 blockers. Remember the thumb rules back then? Well, the non-selective ones are phenoxybenzamine and phentolamine. However, the selective ones are the zosins. So how do you remember all of this? Well, we know that all the zosins are selective alpha 1 blockers, but when we're talking about non-selective, which means it could block both alpha 1 and alpha 2, then what? Then we look at phenoxybenzamine, phentolamine. When it's split into two words, we can see that it can block both. When it's just one word, such as prazosin, that's alpha 1. Alpha-zosin or terazocin, is alpha 1. So I know it's not the most ideal way to remember, but I bet you anything, if you write this in your notes and actually circle the words just to remember, it will come back to your mind. I promise you. Okay, and beta blockers. We know that they're all olols, right? But there's a little trick to it. The thumb rule for beta blockers is that the selective beta blockers are A to M in first name letters and non-selective in N to Z. Whoa, what does that mean? Well, any beta blocker that is A, E, these are A to M, right? There's another one called metoprolol, and those are selective beta blockers. However, non-selective beta blockers are N to Z, such as timolol, nadolol, propranolol, right? These are non-selective, so remember that thumb rule. This guy right here is a little weird. This kind of has the best of both worlds. It blocks both alpha 1 and beta 1 together. It is carvedilol and labetalol. These are both alpha 1 and beta 1 blockers. And we know the reciprine and guanethidine as neurotransmitter uptake inhibition from our first story of the day. So let's take a look at each drug separately. Alpha 1, alpha 2 blockers, and it's anti-adrenergic. The drug is phenoxybenzamine, phentolamine. Phenoxybenzamine is irreversible. Phentolamine is reversible. This is because it treats pheochromocytoma, and phentolamine is responsible for reversal of local anesthesia activity. So it blocks both alpha 1 and alpha 2. Now, funny thing is phentolamine is easier to remember because remember that whole concept about local anesthesia being very highly active, right? Well, to prevent that activity, to decrease the duration of local anesthesia, we're going to need a alpha 1 blocker, and phentolamine is the magic. So anti-LA, right here, guys. Perfect. Anti-adrenergic drug for LA, phentolamine. Cool enough, guys? Perfect. Now, well, in that case, pheochromocytoma and phenoxy is just another way to remember. Phe. Okay? Alpha 1 blockers only. We're talking about the zosin, guys. Selective. prazosin, terazosin, doxazosin, treatment of hypertension and urinary retention. Blocks alpha-1 only. We know how this works. It reduces peripheral vascular resistance, therefore reduction in blood pressure. Beta-1 and beta-2 blockers. These are non-selective blockers. So anything past N to Z. Propranolol, timolol, and nadolol. So propranolol crosses the blood-brain barrier. It treats hypertension directly by acting on the heart, treats angina and myocardial infarction again by acting on the heart itself. Beta-1 and beta-2. Timolol and nadolol does the same thing, but a little bit more potent. How do you remember that it is more potent? Well, the letters NT are involved in the word potent, treating hypertension and glaucoma. It blocks, oh, this is another mistake, guys, sorry, beta-1 and beta-2. Thank you for cooperating, you guys are great. I know it's a dry lecture and you guys made it to the end. Okay, beta-1 blockers only. Remember, A to M were all selective and the others were non-selective. Therefore, A to M is beta-1 blockers only. These guys will treat hypertension by direct action on the heart and kidneys. So now kidneys are involved, right? Blocks beta-1 only. Then the weird one, carvedilol, labetalol, treating congestive heart failure. Now, hang on a second. This is weird. Congestive heart failure means the heart has already stopped. Then why would we use blockers to stop the heart again? Well, because the fun fact is that it resets the heart. What does that mean? Well, think of it this way. In congestive heart failure, all the receptors of the heart are down, right? Unless there are some remaining. What these blockers do is they go around and stop all the heart receptors even more. It locks the receptors, kills the heart and all the blood vessels, stops them all, and then your brain goes, oh my God, my heart and my vessels are down. I gotta do something. Let's restart. So it jump starts your heart. Remember that word, jump start, because what do we jump start? We jump start a car. So carvedilol and labetalol are all treatments of congestive heart failure by resetting the heart. How cool is that mechanism, guys? Is it just me, or is physiology and pharmacology really interesting? Okay, I'm sorry, I'm trying to keep you guys awake at this point. Well, thank you guys for being so patient with us. Drugs affecting neurotransmitters only, and that brings us back to square one. Remember reserpine from the first slide that we talked about today, that it inhibits the transports into the vesicles, proning the norepinephrine to degrade outside the vesicle. See, when dopamine is converted into norepinephrine, and then norepinephrine is transported through the vesicles in order to be protected, well, reserpine blocks that. And therefore, it reduces norepinephrine components into the synapse. Therefore, it's an anti-adrenergic drug that affects the neurotransmitter. Guanethidine, on the other hand, is one step ahead. If this guy right here couldn't work well enough and failed, well, we will have guanethidine to take care. It prevents the opening of the vesicles by stopping the release of the norepinephrine. Even if norepinephrine did not get degraded and made it into the vesicle, then normally with calcium influx, the vesicles open up and cause the release of norepinephrine. But guanethidine prevents the opening of the vesicles. So it's the real Gotham City villain. Gotham City villain, guanethidine. Okay, just another way to remember, guys. And that brings us to the end of our lecture. So our references are Lippincott for pharmacology and Litton-Fallis for dental management. Thank you for watching, you guys. I know we've kind of went on a dry spell here, but I really hope our little tricks and tips and stories and diagrams help you remember the notes. So please come back for more lectures like this one, and we will make sure you become really, really strong for these exams such as AFK, INBDE, and BDS, DDS, and NEET courses. Thank you so much, guys. See you again at the Tooth Factory.